started. So today you're at the Navigator Training Focus Series. We're going to be talking about Xylazine, a public health update, and we have an expert in the house. And this is something I know you guys have been wanting for a while, so we're really excited to bring this to you. As you know, we are a part of Public Health Institute, and we do share our materials through Creative Commons. For today's best experience, if you do have a question, I think the most important thing is to address it to everyone, not just the panelist or a person, because everybody else doesn't know the question you asked. So when you look, when you go to the chat, there's a blue headliner. Just make sure that says to everyone, and closed captions are available. I always like to start our trainings with what our goal here at California Bridge. We are 24/7, our mantra is 24/7 access to high quality treatment of substance use disorders in all California hospitals by 2025. I would really like to add low barrier to this. That's one thing, if we could always add the low barrier treatment for our patients. So what is the CA Bridge model? Well, very simple, threefold process here, and it's revolutionizing the system of care. First is low barrier treatment. Those are our doctors giving buprenorphine in the emergency room, low barrier care, no urine drug screen. They accept what the patient's telling them. So that's the first focus. The second focus is what our navigators do, what you're doing daily, connecting our patients to care and community. And that could be treatment, that could be outpatient, that could be telehealth. We know that there's so many options and choices that you've paved the way for these patients. So we're really proud of all your efforts. And then, of course, the last pillar is the culture of harm reduction. And I know for some of you, you're still battling in your hospitals with the stigma and prejudices. So again, we appreciate you. You're not a lone wolf. You'll hear from a brilliant speaker today. So you have support. So we're always here to say, if you need help, let us know. We're here to help you with spreading a culture of harm reduction. And we're so proud of all of our hospitals. I know there's almost 200 that have ordered naloxone for reversal. So we're really excited about that. So briefly, our announcements, our next Navigator Focus series next month will be substance use and pregnancy. This is another one that people have really expressed an interest in. So we're excited to bring you that, as well as trauma-informed care. And then August, you guys know, is International Overdose Awareness Month. So we will be talking about that in August. Our Navigator update, just to let you know, on June 12th, we will be giving you an update for California's Community Health Worker Certification. I will be going over some new developments, so we're really excited about that. And then our new project, our Navigator Peer Support, we are really very excited about starting this. We know that this has been such a great experience for you guys, de-stressing and rejuvenating and battling challenging times together, and just a place for you to feel safe and have confidentiality. We know what you're dealing with, as well as grief and loss. Some of our patients are not making it through this opioid epidemic. So again, come join our Navigator Peer Support. It is ran by you guys, all right? So Xylazine. Before we get started, I did want to just let you know on the recent data that was presented to us, and that is basically, what's the prevalence here in California? You're going to hear from our speaker, and she's at Penn State in Pennsylvania, and she is the expert because they do see Xylazine. But here in California, we're not seeing much. So I wanted to share with you what we found. And basically, this is the report comes from the department from the Drug Overdose Toxicosurveillance Reporting Program from all hospital EDs. This is non-fatal overdoses, so they would test and check for what is in the systems of patients that have overdosed. So for Los Angeles, as you can tell, 83% are opioids. So fentanyl, you guys, is still the biggest cause of overdose. There are some methamphetamine, combined use, THC and metabolites, 17%. And then there is a note, the xylazine and fluorofentanyl were not present or detected. So that is for Los Angeles. For Sacramento, similar results, except for them, they were 100% opioid. And then for San Francisco, there was a note that they did find fluorofentanyl and bromazole. So that was what we're seeing, and this was the last quarter for last year for December 23 report. Nothing is out new, but I did want to let you know what's trending right now. So with that, I am going to move on to our subject matter expert speaker today. Very proud to introduce Dr. Jeanmarie Perrone. I'm so happy that you could be here today, and I'm going to allow you to introduce yourself.
Thanks so much. It's really a pleasure to be here. I've worked really closely with CA Bridge, specifically with Andrew Herring at Highland for the past 5 years as we implemented a low barrier buprenorphine program, but also expanding to include injectable medications from the emergency department. So we did a clinical trial on Brixadi versus sublingual, and that trial is still ongoing, but it's given us a lot of opportunity to learn about barriers to care post-emergency department and how we can mitigate that. So I love the work you're doing. We do a lot of similar things in Pennsylvania. I'm a professor of emergency medicine and addiction medicine at the University of Pennsylvania, which is actually pretty close to the coast, which might influence why we get some specific, high prevalence of fentanyl and other drugs. And we also work in the city of Philadelphia, which is a place that has been, has had one of the highest overdose death rates of any large city, about 3 times the numbers from New York City. So it's really a place that's been heavily impacted. We saw fentanyl here as the predominant opioid around 2019 and 20, right around the pandemic. And about the same time, we started seeing more descriptions of xylazine use. So my comments today are going to reflect my experiences as an emergency physician taking care of this patient population, and also as the director of our addiction medicine programs in our health system. So really getting feedback from a lot of different places where people access care. So I'm just going to share my slides. Oh, it's the old system settings. Yes. Sorry about that.
Okay, well, she's getting her slides ready. I just want to fill in some time with asking you guys, are you seeing any known xylazine cases? Like I said, our data is not really, we don't have any data that says it is in our area. It doesn't mean it's not coming, but definitely, we want to hear from you. There is a question about a start code.
I'm here.
Okay, there is no.
So sorry. I just got a new computer, and so the settings did not include, or not. I have not been on a Zoom meeting yet.
No problem. I'm back. I'm covering. So again, no start code. You will get a evaluation for your CEU. You will be emailed in a post-event email. Okay. I hope that answered. Okay.
All righty. Here we go. So let me just move the picture of everybody. So again, a lot of my experience comes from emergency medicine and our addiction medicine consult service at our busy downtown hospital. So I have no disclosures. Just want to talk, as you know, the Biden-Harris administration designated fentanyl as an emerging threat last spring. In response to that, we collated a lot of our experiences and put together multiple webinars for NIDA, for the Office of Drug Control Policy, directly to NIDA leadership, and really got some documents together about how we are managing xylazine in our health system. So I want to go over today. We're going to interpret data from overdose surveillance. Some of that was already shared. And then I want to share our experiences. We participated in that drug overdose toxic surveillance program that you shared already. So I'm going to show you what we see on our end with patients who are xylazine positive. And we're going to talk about how we treat this combined syndrome and ways that we can manage and mitigate the risk of overdose. So many of you might know that xylazine is a pharmaceutical agent that is not approved for use in humans. If you go back to the 60s, it was actually, there was an FDA application for using it as a blood pressure medicine, an antihypertensive, but it actually caused some low blood pressure and some sedation, much like the drug we use today, clonidine. It was never approved for use in humans, which also means that it's very limiting in our ability to we can't give it to humans in clinical trials to figure out if patients actually have withdrawal. That might be the next step if this was a drug that was available for use in humans, but since it's not, it limits our ability to do clinical trials with xylazine specifically. So it has been used for about 30 years as a veterinary sedation medication. It does cause pain relief, so it's an analgesic. It does relax muscles. It's available in multiple different doses. It's often used in combination with other veterinary sedatives, including ketamine and barbiturates. Xylazine as a drug of use by patient populations was first described in heroin use in Puerto Rico. And allegedly it emerged there because it was easy to divert it from the abundance of horse farms there that were using it for, sedation for procedures in horses. So there are a couple of articles that describe their early experience, but what's most important is that the population of people who used drugs at that time actually reported this emergence of skin ulcers. And in one of our NIDA webinars, they actually had one of the people who were involved in that describe his experience. So there certainly was, reflective of what we're seeing today. So why is the xylazine in there? Fentanyl is extremely inexpensive. So usually an adulterant is added to be psychoactive, but to also make the drug less expensive. In this case, that probably doesn't fit that paradigm because xylazine's cheap, but fentanyl is cheaper. So it's not that it's expanding the drug. Perhaps it is actually being added to make a less lethal, potent high, something that causes less respiratory depression and makes it, if you will, a little bit safer. But nobody really knows why it's there, but it's not because it's stretching the drug for profit. So as we discussed, the prevalence is very low out west, but this is the same. When Andrew and I started our clinical trial, we were seeing about 60% fentanyl in our drug samples in 2020 in Philadelphia. And at that time, you were seeing still a lot of black tar heroin and maybe just a handful of fentanyl cases. As you know, fentanyl has spread from east to west, and we anticipate the same thing for xylazine. So when xylazine is used IV, the effect is pretty rapid within 1 or 2 minutes. It is also absorbed intramuscularly or through the skin or orally or intranasally. So we do see people who use it intranasally, not so much orally. The duration of effect is about 4 hours. And so some people have also said that it adds length to their fentanyl use so that, you may use fentanyl every couple of hours, but if you have additional xylazine in it, it prolongs the sedation. So maybe you're not using as frequently. And again, it's structurally analogous to the drug clonidine, which we have some familiarity with in its use as something to mitigate opioid withdrawal effects. So I just want to talk about some experiences and research that we've done that has actually informed some of what we know about why people use these drugs. So we got on a Reddit forum about xylazine. It was really about fentanyl, but we looked for posts that also included information about xylazine. We call this chatter, and we use natural language processing to review thousands of posts on these subreddits. So many people are having dialogues about buprenorphine precipitated withdrawal, how to mitigate opioid use in between being on buprenorphine. There's really a lot of information on Reddit specifically with great details about people's experiences using drugs because it's an anonymous forum. So we use that to get some descriptions about why people are using xylazine, what are their symptoms, experiences, withdrawal, complications, et cetera. And then because we use natural language processing, we can look at thousands of posts and cull themes that we see. So from that, I can share a little bit about what we see. So we posted a survey on Reddit, and we asked people, do you seek out xylazine intentionally? And 2/3 of patients said no. Which means, a few do actually seek it out. And I would say that echoes what I see in person. Most of our patients are trying to avoid it, but some people actually are seeking it out. And then the most common routes of use are intranasal or injection. We didn't actually ask about smoking. I know that is a common pattern for fentanyl use in your area. It's not as common on the East Coast. So what does xylazine, the presence of xylazine, do in patients who are exposed to it in the setting of overdose? This is data from something we call the toxic registry, which means it's patients who are seen in an emergency department following an overdose. They are seen and evaluated by a medical toxicologist. That's someone who's done a fellowship in poisonings and overdoses, similar to what I did. And it's at 9 emergency departments around the country. And what they found, so they talk to the patient, they get their reasons for the overdose, what the patient was intending to use, and then they send the blood for very extensive evaluation by the clinical, a very elaborate clinical lab that's also in Pennsylvania. That's the same lab that's used in that DOTS overdose surveillance study that we were participating in. But in this study, basically, they found 90 patients had xylazine detected in their overdose. So it was xylazine plus fentanyl versus fentanyl alone. So 231 of the 321 had fentanyl alone. They found no differences in rates of sedation, no differences in rates of low heart rates, bradycardia, or intubation. So it looked basically clinically silent. There was no evidence that xylazine was even detectable, clinically. They also found that patients who had bad outcomes like CPR and prolonged coma was more common in the patients with xylazine that was not detected. So the fentanyl-only patients. And that, has been hypothesized that, xylazine and an opioid might actually be less toxic than fentanyl alone. So some of the theories on that is if you look over the past 3 years that we've been doing this study, we actually are seeing increasing xylazine relative to fentanyl in the drug supply. So these are years 2021, 22, 23, and that red part on the bottom reflects patients whose drug samples actually contain xylazine greater than fentanyl. So 31% of the samples actually contain more xylazine than fentanyl. And fentanyl is the thing that really stops you from breathing. Xylazine is really just sedating. So you could think of xylazine as something comparable to Xanax or Valium. So it's really not going to cause that potent respiratory depression that we see with fentanyl. So in actuality, if you replace some of the fentanyl with xylazine, you're going to see a less toxic effect when it comes to overdose. So our clinical manifestations when we're managing overdose is that, a lot of times patients get reversed with naloxone, but might still be sleepy. So when sedation continues after naloxone administration, consider that perhaps the patient's also using benzodiazepines and they weren't reversed, or that they've been using cocaine and and methamphetamine, and they have a post-stimulant washout syndrome, so they're still kind of sleepy from that. Or there's other sedatives on board, including alcohol and including xylazine. But the fact is they're awake enough to continue breathing, and that's the most important part. And if you just do supportive care over the next couple of hours and close monitoring, most of these patients can just be discharged when they fully wake up. So we often get asked, is there a role for a xylazine reversal agent? There is a reversal agent for benzodiazepine. So we have naloxone for opioid overdose, and that works very well, and you're very familiar with it. But we actually have a reversal agent for Xanax and Valium overdoses, but we almost never use it. And that's because when you give it, it will cause reversal of the benzodiazepine sedation, but it actually might precipitate withdrawal. So we never use it in patients who use drugs because we presume that they're dependent on those benzodiazepines. And if we suddenly remove all of the benzodiazepine, they might have a seizure or high blood pressure or fast heart rate or any of those manifestations. So we really sort of use that analogy to say that we probably really don't need a reversal agent. The most important reversal that we need to do is to reverse the opioid with Narcan. So how about testing for xylazine? In our hospital about 2 years ago, we were able to implement a very fancy test for detecting xylazine by gas chromatography mass spectroscopy. It does not come back in any clinically relevant time, but the results are there on the chart. And so we did a chart review of 121 patients who were xylazine had a xylazine test sent, of which about 2/3 were xylazine positive and 1/3 were xylazine negative. So the reason the xylazine test was sent was because the clinician had some suspicion for xylazine. And whether or not we could predict who might be positive for xylazine, we were able to find the following factors: patients who were younger, patients who were white, patients who also had fentanyl detected or methadone detected, and patients who were less commonly found in the ICU. So you can see some of our specific results, but we think methadone was really just a marker for patients who received methadone to manage opioid withdrawal while they were in the hospital. So overall, what we also learned was that we could detect that xylazine between 1 hour after arrival up to about 30 hours after arrival. In another study that's actually being published in late June at another conference, this is the abstract, patients who were admitted to a treatment unit in Baltimore also had xylazine detected about 3 times a day. They tested for it for a number of days. And what they found also was that they were able to detect fentanyl for about 74 hours, but xylazine for about 31 hours. So again, we need to know that window of detection, because if someone comes in, 2 days after their last use and they're xylazine negative, it really helps you interpret that. It could just be because you are, outside of the detection window. And up until now, we really haven't had that data. So between our study and this study, I think we have a better sense of what that detection window will be. That will still also depend on the amount of drug that you were exposed to. So what about using xylazine test strips? In our area, you can imagine we do give out a lot of xylazine test strips, and people say that they would use them to avoid xylazine. But in our area, you might have seen that we have xylazine in some settings as much as 95% of the drug samples contain xylazine. So if you're using these xylazine test strips and there is no alternative drug to your drug supply, it's not going to be very helpful. But in places like somewhere between California and Pennsylvania, you might actually find a use for xylazine test strips because there might be alternatives to xylazine fentanyl in that region, and that would help people avoid using xylazine adulterated fentanyl. Along with that, we just published something at the American Society of Addiction Medicine where we used xylazine test strips on patients who we knew were xylazine positive. That same cohort of patients where we're doing the xylazine test in our hospital, we took samples where we knew the xylazine was present, confirmed by GC mass spec, and we just used a xylazine test strip. And we were able to find that they were actually pretty sensitive at detecting xylazine in human urine. So this might be the first time that we could say, hey, if you want to start looking at symptoms of xylazine, we could use xylazine test strips to detect whether or not the patient actually has been exposed to xylazine. So this we anticipate will become more common. Right now, it's not approved for that use. We're not endorsing it for that use, but you can see some harm reduction groups potentially going in that direction. So another thing that we asked in our Reddit forum was whether or not patients felt like they've been having a different kind of withdrawal since they started using xylazine and fentanyl. And so you can see the questions here. So a lot of people said that they feel that a distinct withdrawal syndrome from xylazine, and that since they started using their withdrawal from other drugs, presumably fentanyl, has gotten a little bit worse. And this is really something that when you speak to patients in our area, they absolutely say that they feel withdrawal from xylazine. However, when we admit patients to the hospital for treatment, we see something that looks like opioid withdrawal. We really struggle to find anything distinct. We don't see high blood pressure. We don't see fast heart rates. We don't really see anything that looks distinct. It doesn't look like benzodiazepine withdrawal or alcohol withdrawal. So we did another chart review looking at patients who were xylazine positive, and we had 3 investigators looking at these charts, and really, and this was a retrospective, chart review. So, not the best methods, but we were able to find that, most patients had a reason for whatever their withdrawal course was. They also were taking benzodiazepines, so they had a course consistent with that. If they were appropriately treated for their opioid withdrawal, they didn't really have any other distinct syndrome. Some patients were undertreated for their opioid withdrawal, and so we feel like that contributed a lot to why they might not have, why they may have left early, et cetera. And again, we didn't see anyone who had seizures or agitated delirium or anyone who needed to be in the ICU. We also didn't see, as I said, any significant vital sign abnormalities. So I just want to point out that, as I said, fentanyl has been in our drug supply for the past 4 or 5 years. And when we try to estimate how much opioid a patient is being exposed to with fentanyl, we've used some estimates that the DEA has given us. I know a lot of you guys aren't very clinical, but when we treat a trauma patient with fentanyl, we treat them with something about 50 micrograms of fentanyl per dose. Maybe if somebody really has something severe, they'll get 100 micrograms at a time, maybe 200 micrograms at a time if they're really, have a femur fracture or significant long bone fracture. So 200 micrograms is 0.2 milligrams. And in these bags of fentanyl, we're seeing 2 milligrams per bag. So that's about 10 times the amount of a therapeutic dose. And then we're seeing people who are using 40 bags a day. So their opioid requirements are out of the sky. Nobody knows how to treat this degree of opioid dependence. It is very not comparable to what we knew in the previous era with heroin. So people are using about 80 times as much opioid as they have in the past, and that is really significantly impacting their onset of withdrawal. So what we feel is that xylazine withdrawal is really an overlapping symptoms with opioid withdrawal. What people describe as anxiety, dysphoria, and restlessness. With opioid withdrawal, people get lots of restlessness, anxiety, and dysphoria, along with all those other symptoms. And then benzodiazepine withdrawal, which is also a co-exposure for many of our patients, also includes these symptoms. So very hard to drill down and call it xylazine related. When we find in our prospective cohort of patients being admitted to the hospital with opioid use and co-exposures of xylazine, that we really don't see people who have a distinct withdrawal syndrome. And if their opioid dependence and withdrawal is aggressively treated, we don't see any other emerging withdrawal phenomenon. We do use clonidine. We don't use as much benzodiazepines. We use clonidine, gabapentin. We use oral ketamine a lot. And sometimes we use olanzapine or some antipsychotics. And if you can, keep a person pretty calm, we don't really see the emergence of objective criteria of withdrawal. So back to the survey, we asked people what kinds of complications they have of xylazine use, and it definitely emerged that people described the use of the experience of increased skin and soft tissue infections, increasing overdoses, increased ED visits, et cetera. So I wanted to go over the wounds. Now, I'm sure you've Googled wounds, seen wounds in talks, but this was a young woman who I took care of a few months ago, and she was just showing me these small ulcers. This one here on the right emerged in her antecubital fossa or her elbow where she was injecting. The other one was on her lower leg where she was not injecting. And they had both appeared in the past few days. She was coming in, she had been using a little bit less fentanyl, had been recently in treatment, had gotten out of treatment, and now was using about 2 bags a day. So didn't really have heavy use. She was housed and was really, kind of just making sure that everything was okay. This was a subacute wound on a young man who came into the emergency department. He was unhoused. And this, I would say, is comparable to the progression of the wound that the young woman had. So it starts as a shallow ulceration that deepens over time. It may have crusting and drainage, and you might see a few of them over, a period emerge. So you can see on the right there that they have 2 or 3 smaller lesions, 1 big lesion. And then what we'll see over time is that all of these lesions will coalesce into a very large ulcer. It'll be deep, it will be, wide, and it will require a lot of wound care in order to prevent it from, continuing to ulcerate and be necrotic. We recently published an article about where we're seeing these wounds, how we're managing these wounds. In the darkest red parts here of the patient's, body diagram, we're primarily seeing them on the forearms and on the legs. And so you can see both the front and backs of the forearms and the front and backs of the legs. And so, this is not always where people are injecting. Oftentimes people will, like the young woman, show me things that did occur at an injection site and then other things that are occurring not at an injection site. So really problematic. And this is a major reason why people are coming to the hospital now. So why are the wounds happening? We're really not sure. There's been a lot of theories proposed. A lot of them don't make sense because we are seeing wounds distal from the injection sites. So cytotoxicity, it means that the drug Xylazine is directly toxic to the skin and tissues. But we know that animals don't get ulceration, so it can't be cytotoxic after 1 or 2 doses. It's really chronically, possibly cytotoxic. It causes vasoconstriction, which means constriction of blood vessels. That's one of the active ways that it works pharmacologically. So people have talked about not enough, blood supply to the area. That also might explain some of the local effects, but doesn't explain the distant wounds. People are definitely injecting more frequently now because fentanyl is shorter acting than heroin was. So, people inject 10 or 12 times a day. That increased violation of the skin may contribute to more reasons why people are getting wounds. People have described the fact that because they're sleepy longer, people wake up, they've been sleeping in a funny position. So if that funny position includes laying on your leg and you already had a wound there, there might be compression effects that worsen that wound. There is a component of elevated blood glucose sometimes associated with xylazine, so perhaps there's poor tissue healing related to that. And then universally, these patients are malnourished. They're cachectic, they've been living on the street, they're primarily using a lot of drugs and not really eating. And so that certainly contributes to wound healing in surgical patients. So what are the primary tenets of wound care? You can find a lot of the details on our websites, but cessation of injection into the wound is very important, but it doesn't mean cessation of injection drug use. We, of course, want everyone to stop using drugs, but we're going to help them to at least stop injecting in the wound, and with good harm reduction conversations, make goals around what the patient is motivated to do. A lot of our surgical colleagues don't want to do procedures on these patients until they've been in treatment for 6 weeks or 6 months or whatever silly rules they're throwing at them. But we just try to work with the patient to at least enhance their opportunity for good wound care and opportunities to mitigate the ongoing damage. Traditionally, with surgical wounds or diabetic wounds, surgeons take patients to the operating room to do debridement, which means kind of cleaning up the wound, getting rid of all the dead tissue, allowing only the healthy tissue to stay. And what we've learned is that it's better to use something called enzymatic debridement that helps to clean up the wound, but doesn't require them to go to the operating room. And these enzymatic debridement approaches really preserve tissue, which is very important because of the progressive necrotic component of it. They lose too much tissue if they get surgical debridement. So, and then there's also wound coverings like something called BTM, which is like a matrix that can be put over the wound to keep it clean and prevent it from getting infected. And then, of course, we have lots of low barrier wound care places where patients can access wound care supplies, dressing changes, et cetera. Really important in our city with a lot of patients who are suffering from this complication. So I'll close with talking about this DOT study. So as you mentioned in the beginning, there are 3 sites in California that are participating in this drug site study. So it's called DOTS, Drug Overdose Toxicosurveillance. And much like that toxic registry that I mentioned, what we are doing is at the bedside after an overdose, we talk to a patient. We gain their consent. We take a sample of blood and we send it to this fancy lab. We also characterize what the patient experienced in their overdose. You know, did they use more than they normally did? Did they have a sense that, they were, getting something that tasted or smelled different? So getting as much information we can about their drug use experience, and then also getting as much information as we can about their prior drug experience in the past week or two so that we know what else might be in their blood. I'm going to go over some of the results for our site in Philadelphia, but as Sandy mentioned, there has not been any DOTS Xylazine positive, at least the December issue. But really, overall, the Xylazine prevalence on the West Coast is very low currently. So as I mentioned, we are enrolling patients who experience an opioid or stimulant overdose or any undifferentiated illicit drug overdose. And so we interview the patient, we go through the chart and what happens to them after their overdose, and then this elaborate laboratory analysis. So I'm just going to review a patient that we saw in the fall. So this was a 41-year-old man who was brought in by our fire rescue. He was found on the sidewalk with pinpoint pupils and abrasions to his forehead. By ambulance, he was given 2 milligrams of naloxone with improvement, but by the time he got to the emergency department, he was still a little bit sleepy. So he was given 2 more doses of naloxone. In the emergency department, we use very low doses because we don't want to make people sick. And we know that we're not going to be able to fully reverse everything that they have on board. So we really just want to reverse a little bit more of the opioid. So he was given 0.04 milligrams times 2. He didn't get any more awake. He did get a CAT scan of his head because of the abrasions on his forehead. His trauma evaluation was negative. And his urine drug screen in our hospital came back positive for cocaine, methamphetamine, and opioids. And those opioids included fentanyl. That's pretty typical. He was able to wake up after a few hours. He had consented to the study. The blood sample was sent to the lab. So months later, we get these results. So qualitatively, he in fact had methamphetamine, xylazine, norfentanyl, which is a fentanyl metabolite, 4-hydroxyxylazine, which is a xylazine metabolite, cocaine, oxycodone, naloxone, because we gave it to him, fentanyl, bromezolam, metonidazine, and pronidazine. And then we have quantitative levels on this, which are actually very helpful. His fentanyl level is pretty high, and that shows that he has a lot of fentanyl tolerance. His norfentanyl level is also pretty high, which also shows that he's been in chronic use with fentanyl. His xylazine level is a little bit elevated, consistent with what we're seeing for the ratio of xylazine to fentanyl. Again, we knew he'd gotten naloxone. And then he had these 2 nitazines. So nitazines are also opioids. They have been detected in our drug supply more recently in Philadelphia, but there's really nothing too special about them. They are an opioid. They're going to respond to naloxone just like he did. They would also respond to, buprenorphine treatment or methadone treatment. So it's really just another analog. And they were present in relatively low concentrations. And then he also had bromezolam, a very high level of bromezolam. Bromezolam is what we call novel benzodiazepine. It is not available for therapeutic use, but it's quite commonly being found in our drug supply. And really, benzodiazepines by themselves are relatively safe in overdose. They cause sedation, but they don't tend to stop respiratory effort. So, if you look at this patient, he had 5 reasons, 10 reasons maybe why he wasn't going to wake up after naloxone, but his respirations were restored and he was able to be discharged. So there's been a lot of attention placed on xylazine as an adulterant. I would say the number 1, 2, and 3 problem associated with xylazine so far are the wounds and the fact that it's difficult to detect. But I think the most important component of this is that we really need to mitigate use to avoid, progression of wounds. But I think in terms of its, lethality, it's really not causing more fatal overdoses. Naloxone is a really sufficient antidote because what we're really seeing is xylazine in combination with fentanyl, or anything in combination with fentanyl, where we still just need naloxone. I think the jury's really still out on xylazine fentanyl dependence and withdrawal. We know that the fentanyl dependence we're seeing is really catastrophic, and the component of xylazine withdrawal seems a little bit less. But patients say they feel something different, so we are still listening to our patients and looking for that withdrawal syndrome. We have a lot of resources about xylazine on our website. It's Penn Center for Addiction Medicine and Policy, or penncamp.org. We also have a really nice webinar comparable to some of the information I just gave you, but with a little more emphasis on wounds. And we have all of our protocols for buprenorphine initiation, et cetera. And if you happen to find a few years ago, not even maybe a year ago, a substance use navigator from CA Bridge called my charge nurse in my emergency department because there was a California patient visiting Philadelphia, forgot their Suboxone, and that bridge navigator called my emergency department. My emergency department called me, said, how can we get this patient some Suboxone? We connected them to our telehealth, or maybe they got their prescription in the emergency department. I think they weren't in the ED yet, and we were able to navigate them to our telehealth line and get them Suboxone. So we really appreciate the regional network of telehealth and that opportunity. And I know that you guys are doing great work in that space as well. And then here are our resources. All right, I'll stop sharing.
Wow, I love that story, Dr. Perrone, with the navigators, because that's what they're doing, is they're out there navigating patients to get treatment. So that's thank you for sharing. This was so enlightening, Dr. Perrone. Being a navigator and a nurse, there's always the next big drug. And so I like the way you broke it down for us. That's really, useful in what we're seeing patients with. Bottom line, fentanyl is still the most fatal drug out there causing overdose deaths. So I think our navigators are hearing that that's still the most prevalent and the most focus that we need. There was a question in the chat. Let me find it.
About the violence.
Yeah, I've heard several anecdotal reports about xylazine fentanyl withdrawal leading to violent outbursts and patient punching walls, self-harming behavior. Any truth to this?
We see a lot, like I said, we're admitting a lot of patients. We know they are xylazine fentanyl because they have wounds. So, without even detecting them on the front end, we know that people that, are using both, and we don't see anything like that. There are, so many reports of people having violent outbursts after naloxone. And I think that adds to the fear and stigma of rescuing people with naloxone. I've never seen that. I've been an emergency doctor for 20 years. I've given many people naloxone, and, I have never seen that. I think that's part of the stigma that's mitigated and propagated by law enforcement and other antagonists to substance use treatment.
Great. I hope that answered your question, Benjamin. And I encourage you, you're here with Dr. Perrone. Do you have any questions? What's new for you? Was there anything new about this subject, or what was shocking? Anybody have any questions? Because you guys, we constantly get something on Slack about once or twice a week. So don't be shy. We have the expert here. And Dr. Perrone, is this something that's commonly in a community hospital that they would test for, xylazine?
They can't really test for it. It takes really elaborate methods. I know that you guys just passed something where every ER in California now has to test for fentanyl, which I think is really important. It's a long way from being able to mandate testing for xylazine because there isn't a rapidly available test yet. I think the technology of our xylazine test strips will possibly translate to that, but in order to get FDA approval for that, I don't imagine that there's going to be a year or two away.
Okay. Yes, we will have access to slides. We will send that in the post-event email. So no need to worry, as well as with our evaluation. I think this is a really great comment. I learned so much with this presentation. A lot of what I thought I knew was incorrect. Thank you for sharing, Deborah. I think a lot of us feel that way. So we're glad to have the expert with us. Is it safe to say that if fentanyl is detected and ulcer wounds are present, the xylazine use is likely?
If they have wounds, I'm sorry.
Yes, if they have wounds present.
We just gave a talk in, where were we? Phoenix. And my colleague who's from Newark, feels like what I feel, which is, when you've taken care of patients who use substances for years and years and years, there were abscesses and, skin contamination and cellulitis. So people have always had wounds. These wounds look very different to me, but they might not look that different to somebody who hasn't seen them yet. So, abscesses are still very common for people who use intravenous drugs. So calling something a xylazine abscess or xylazine wound, there is no definitive way to say yes or no, but I would say you can somewhat reflect on the prevalence in your area to name it. I think over time, the progression and healing of a non-xylazine wound is going to look a lot different than the progression of a xylazine wound. But sort of on one-off, sometimes my colleagues send me pictures and, we try to judge, but I think for areas that are, um, in areas of lower prevalence, it's probably just an older traditional wound.
Okay. Well, thank you. And there's also another question about some wounds. These wounds are from xylazine are only from injection use.
No.
Okay.
Intranasal use, I don't know about smoking, but intranasal use is definitely associated with wounds. We actually have a very unfortunate individual who has wounds in her mouth, probably from intranasal use, like a tremendous amount of necrosis of her palate from intranasal use. Those are comparable to what we would see with cocaine, but definitely more destructive than what we've seen more recently from cocaine. So intranasal is not. People really wonder whether smoking is a harm reduction strategy. I think the jury's out. I'm not sure where the wounds might show up if you're smoking instead of snorting or injecting.
Right. Okay. Great information to know. We have another question in the chat. How long does it take for a wound to heal completely when the drug is stopped? They've cessated from.
Yeah, it definitely depends on the depth of the wound. You have to understand these patients are the most severe opioid use disorder. So, we know xylazine was in our drug supply since 2010, and I think it just hasn't manifest until recently because one, I think the concentration of xylazine went up. Two, I think because of fentanyl, people were using whatever amount of drug more frequently and more quantity, and so their exposure went up also. And so these are people who, like I said, are using 20 to 40 bags a day, unhoused, the sickest of the sick. And so along with that, malnutrition and other things, if you could restore just one of their problems, like housing or malnutrition, they can heal the wounds. Certainly if they stop using drugs, but some of these huge ulcerations where bone is exposed, it takes a long time to heal regardless of what you do.
Great. Thank you for that answer. We have another question. They want to confirm there is no logic behind why this has infiltrated drug supply. Correct.
I would say, yeah. I mean, I really, the patients say it gives legs, it makes the fentanyl last longer. I can only say our traditional reasons for adding adulterants was more profit driven, and this does not seem to be profit driven. Um, so maybe there is some biological motive to expand drug use, and if you kill your clients, that's going to be bad for your propagation of your drug use.
Right. So the xylazine is something to cut into that fentanyl. So totally makes sense. Totally get that. Thank you. We have Sabrina asking, we have seen wounds on patients who are using fentanyl and deny IV use. Have you seen
Yeah.
that?
I mean, I can't say that anyone I see who has a wound, and I can't say that they haven't been exposed to xylazine. So I wouldn't say I have a great idea of how many people are xylazine negative using fentanyl, but drug use has, historically had a lot of association with, with wounds. So I think it's very possible. And then, other things, endocarditis can cause skin wounds, as emboli go to the skin. So there's certainly lots of reasons why people may have violation of their skin for, different reasons.
Okay. We have another question here about all DOTS data comes from people who consent.
Yeah, so we don't submit their sample. So we might get their sample when they're in triage and blood is drawn, but we only submit samples from people who have awakened enough to consent sometime during their hospitalization.
Great, thank you. We have another question. I'm in this north suburbs of Chicago. Well, welcome, Chicago. And we are seeing xylazine in about 15% of our fatal overdoses. In your experience, will users test for xylazine and change their use based on positive results?
There's a study that I referenced from Megan Reed, who's at one of our other hospitals, and she interviewed people and they said they would do that. I think there's a few different interviews with people who use drugs about how they used fentanyl test strips, et cetera. I think some people would. I think like I said, in the high prevalence area like here, there's not a lot of alternatives. You may spend all day looking for something that was xylazine negative. Now, in our DOTS study, we've enrolled about 20 patients, and only about 12 were xylazine positive. So that's a much lower rate of xylazine exposure. And I'm a little bit on the west side of the city, and most of the drug sampling that has detected a 98% xylazine positive rate is on the other side of the city. So, maybe there's more xylazine negative substance than we have been led to believe. But that whole thing about fatal overdose, like I said, in 2010, we had xylazine in our medical examiner detecting it, but its contribution to the fatal overdose is probably zero. It's probably just xylazine that was there, or xylazine that was there with fentanyl, but it's fentanyl that stops people from breathing. So it might contribute, but I think that the jury at this point looks like possibly xylazine, is less sedating or less respiratory depressant than fentanyl.
Thank you. Thank you. I think those are the questions. There was a few more statements, and I think you answered that with your last comment. There's something about the wounds that they've seen amputations and patients still seeking for xylazine. Is that something that have?
Lots of amputations, lots of open wounds where bone is exposed. There's a published article in the New England Journal of a woman who had wounds on her chest, who was injecting into her neck and had huge necrotic wounds near her clavicles on both sides. I don't favor like a lot of these presentations with all these, extra wounds. You can Google them. They're very necrotic and ulcerative, but to me, it just adds to the stigma that these patients face. So I feel like it's pretty important to, do our best to support this patient population and provide, the best wound care that we can, and encourage people to seek treatment without propagating a lot of pictures around that are, I think more upsetting. And, there's, reporters that talk about, the zombie drug and, just a lot of things that I think are just add to the stigma that we just don't need.
Absolutely. Well, I really thank you for all of your information and sharing this time with us, because I think this was so enlightening. I think you've answered so many questions and curiosity. And I really appreciate you being here speaking to our navigators. This has been awesome, you guys. So I thank you very much. I'm just
Welcome.
going to share my screen again, and we'll wrap this up. Thank you again, Dr. Perrone. We've finished the Q&A, and we do have some post-test questions. Xylazine is used as an animal tranquilizer. What do you guys think about this? Type it in the chat. Cases of illicit xylazine use are documented across the nation. What do you think about that one? Xylazine does not respond to naloxone emergency reversal spray. If there's one thing you've learned from this training today, we know that fentanyl is still causing fatal overdoses. So think about this question. You cannot overdose on xylazine. Okay. And one of the side effects of xylazine is wounds throughout the body. So we hope you'll get the answers to these questions. I'm not going to give them to you now because they're on your post-test evaluation. But I think we answered all of these. And if you do have a question, let me know. But we just kind of wanted to point out the key takeaways. And here are resources on our website if you need to follow up with our trainings or anything, our buprenorphine quick start algorithm guide, anything you need to help your patients, as well as our CA Bridge Academy. We have free online resources with CEUs, so please use this. It's asynchronous, which means you can go on at any time. There's no formal training, but you can go on there and complete your CEUs. And so we're really excited for that CA Bridge Academy. If you would like to contact us, please contact us at mentors@cabridge.org. We are here for you at any time. We've just wanted to make it an easier one-stop email, mentors@cabridge.org. As you know, you always have your mentors in your region. If you don't know your mentor in your region, mentors@cabridge.org will get them to us. So all over California, we have provided territories. So these are expert navigators that mentor our newer navigators. And again, we have them all the way from Northern California to San Diego. So this is your navigator mentor team. And again, I'm Sherry Cisneros. We are going to finish 2 minutes early. If anybody has any more questions. No, I don't see anything in the chat. I see a thank you. And yes, again, Dr. Perrone, thank you so much. This has been one of our awesome trainings, and highly, highly recommend to anybody, and even to watch it again. There was a lot of information in that. So again, we appreciate your time and thank you.
Thanks for having me. And thanks for all the work you do. I know how hard it is to corral a big group of people who cross a huge state. So kudos to all your work.
Great. Thank you. Have a great day, guys. Bye.